The new guideline document to manage pneumothorax includes evidence-based questions on the optimal management. It provides a range of recommendations to help clinicians improve their daily practice, including rationale and evidence behind the suggestions. So let's have a look to the new guidelines to manage pneumothorax.
Pneumothorax is not new. Hippocrates documented to be the first who came over with it as a succussion splash on shaken in hydropneumothorax. Itard and Linnick described the full clinical picture of pneumothorax around 1819. And the first modern description of pneumothorax in young people was documented in 1932. However, the treatment of pneumothorax wasn't begun as a standard procedure until the Second World War. The primary spontaneous pneumothorax, they don't occur in normal lungs. They are thought to result from rupture of apical pleural blips beneath the visceral pleura, which have been identified up into 80% of the affected patients on CT scan and 90% at the thoracoscopy, compared only to 20% of the control subjects. The blips have no epithelial lining and result from rupture of the alveolar wall.
The clinical guidelines may have reduced patient admissions with spontaneous pneumothorax mortality in England and Wales between 1991 and 1995 at 1.3 per million for men and 0.6 per million for women.
Classically, patients is a tall, thin male aged from 20 to 30 years old with an increased negative pressure shear forces at the apices being implicated in the subpleural blip formation. Similar mechanisms may account for the predisposition of patients with Marfan's or Marfanoid hepatus to this condition. Smoking, including smoking cannabis, is associated with a 12% increased risk of developing pneumothorax in otherwise healthy men. Female smokers have an overall 8-fold increase in the risk of development of spontaneous primary pneumothorax. And the genetic factors have been identified in a small number of familial clusters. Regarding the secondary spontaneous pneumothoraces, they are less common and account for approximately 10 to 20% of all spontaneous pneumothoraces. The classic presentation would be that the patients will have underlying lung disease and the age group will be more than 50 years old and they have smoking history. Also, the most interesting thing is that they respond differently to a needle aspiration than younger patients or non-smokers. Looking at this diagram, it will show us the differences between the primary and secondary pneumothorax, and you can see that the age group less than 50s will be primary. The predominant one will be the primary, and more than 50s will be the secondary pneumothorax. And here is the different presentations to emergency department from 2010 to 2020, and you can see here the primary pneumothorax and the secondary pneumothorax according to the diagram. Regarding the causes of the secondary spontaneous pneumothorax, we have obstructive airway disease like asthma, COPD. We have infection also. The infection, we have either tuberculosis or pneumonia, and particularly pneumocystis jirovecii. So approximately 1 to 2% of HIV infected patients and 5 to 10% of patients with pneumocystis jirovecii, formerly called PCP, develop a pneumothorax. With more effective treatment, this incidence is falling. Also, we have suppurative lung disease. You can see that cystic fibrosis or bronchiectasis and lung abscess, these are the causes also for secondary spontaneous pneumothorax. And the last one would be the interstitial lung disease. We have sarcoidosis, idiopathic pulmonary fibrosis, and hypersensitivity pneumonitis. And also we have pneumoconiosis. There is a form, or there is a type of secondary spontaneous pneumothorax, which is the catamenial pneumothorax. So the catamenial cause of pneumothorax is a cause specific to women. The catamenial pneumothorax occurs at the time of or within 72 hours of menstruation. The cause is endometriosis, which has been reported to account for approximately 5% of pneumothoraces in women. Typically, the female patient will be aged from 30 to 40 years old. The right lung will be affected over 90% of cases, and she will have been previously diagnosed with pelvic endometriosis. So approximately 1/3 of cases of pelvic endometriosis. Half of these patients will have a recurrence of pneumothorax in the following 12 months. Hormonal treatment may improve the prognosis, but given a high recurrence rate, referral for further investigations and consideration of surgery is warranted. This table shows the difference between the primary and secondary pneumothoraces. In peak incidence of age, in primary it will be from 20 to 30 years old, while in secondary will be 60 to 70 years old. Male to female ratio will be 6:1 in primary and 3:1 in secondary pneumothorax. Etiology, as we said, it will be a ruptured subpleural bleb, while in secondary it will be various according to the etiology that we talked about. The proportion of all spontaneous pneumothoraces in primary it will be 80 to 90%, while in secondary will be 10 to 20%. The 1-year recurrence rate without pleurodesis in primary pneumothorax it will be 25%, while in secondary pneumothorax it will be higher dependent on the underlying conditions. Regarding the pneumothorax risk factors, we have Marfan syndrome, smoking, including smoking cannabis, tuberculosis, diving, histiocytosis, lymphangiomatosis, and as we talked about, the catamenial pneumothorax. Talking about pneumothorax investigations, we have different ways to investigate pneumothorax. The first one will be the chest X-ray. The posterior anterior radiograph has a sensitivity of about 80 to 85% at identifying small pneumothoraces. Also, sometimes pleural effusions are seen with the chest X-ray. The second one will be a CT scan. CT scan is considered as the gold standard at identification of pneumothorax, and it is particularly valuable when radiographs are difficult to interpret or specific drain placement is required. For example, bullous lung disease, loculated pneumothoraces, or surgical emphysema. The third will be the ultrasound. It shows promise with reports of sensitivities at identifying pneumothoraces in trauma and post-procedure. For example, in lung biopsy patients of about 95%. However, it is highly user dependent, and for patients with suspected pneumothoraces, radiography has the advantage of identifying unexpected causes of pleuritic pain, for example, infection, carcinoma. Having said this, with the increasing use of ultrasound in emergency medicine in the hands of an experienced user, it can now reliably detect pneumothorax better than anteroposterior chest radiograph. The fourth one would be arterial blood gas. Arterial gas monitoring may demonstrate hypoxia, but the formation gained is unlikely to alter the management plan. The main use is when administering the supplemental oxygen to patients with pneumothoraces secondary to COPD. Does the pneumothorax size matter? The most useful investigation is the erect PA chest X-ray, despite the fact that it tends to underestimate the size of pneumothorax by virtue of it being a two-dimensional image for a three-dimensional structure. Historically, pneumothoraces were described in subjective terms such as small rim, moderate, and halfway to the heart border. The British Thoracic Society recommends the intervention of pneumothoraces of sufficient size, typically more than 2 centimeters, on the chest X-ray or CT scan, depending on the clinical context. The rationale for using 2 centimeters as a cutoff for indicating a large pneumothorax is that this approximates the point at which up of half of the lung volume has been lost. The American College of Chest Physicians recommends measuring the apex to capilla distance with the distances greater than 3 centimeters indicating a large pneumothorax, while the 2023 British Thoracic Society Guidelines clarify this measurement at both hilum and apex level. So there are no international consensus size. However, in 2023, British Thoracic Society Guidelines clarified that size alone is not an indication for inserting a chest drain because there are high-risk characteristics, there are symptom-driven approach, and also the most important thing is how to follow up those patients.
Pneumothorax used to be managed conservatively. In 1993, British Thoracic Society Guidelines suggested aspiration. If it fails, then chest drain is indicated.
In 2010, the British Thoracic Society Guidelines advised for chest drain insertion again upon the failure of aspiration. And you can see here, this is the pathway for spontaneous pneumothorax, which has been divided into two parts: the management of primary pneumothorax and management of secondary pneumothorax. If we look at this box, the box said here, in some patients with a large pneumothorax but minimal symptoms, conservative management may be appropriate. So since 2010, conservative management was an option for managing patients who are presented with spontaneous pneumothorax. And you can see here in this table the difference of the managing steps of pneumothorax between United States, UK, and Europe. And you can see most of them they adopted the conservative management for pneumothorax, for spontaneous pneumothorax. In 2023, the guidelines from British Thoracic Society are adopting a more conservative approach and looking at ambulatory management of pneumothorax. These new guidelines focus on patient symptoms, and those patients will be managed conservatively if they are asymptomatic or if they tend to avoid the procedure. Symptomatic patients and those admitted for observations should receive high-flow oxygen, which is 15 liters per minute via non-rebreathing mask. This reduces gas pressure in the pleural capillaries, increasing air absorption and resolving pneumothorax faster. In COPD patients, they should use fixed concentration of oxygen. In 2023 guidelines, the British Thoracic Society mentioned high-risk characteristics, which, if they are present and it is safe to intervene, the patient needs to have chest drain to be inserted. So high-risk characteristics are hemodynamic compromise, as in tension pneumothorax, significant hypoxia, bilateral pneumothorax, underlying lung disease, age more than 50 years old with significant smoking history, and hemopneumothorax. Looking at the guidelines, we have two options. If the patient is asymptomatic, we'll go to the conservative care. And in conservative care, we are managing either primary or secondary pneumothorax. In primary pneumothorax, regular review as an outpatient for 2 to 3 days or 2 to 4 days. And if the patient after that becomes stable, we will the respiratory team will review the patient, or they will follow up with the patient in 2 to 4 weeks by the outpatient department. But if the patient has got secondary spontaneous pneumothorax, those patients should be admitted and to be managed as inpatients. And then if they are stable, they will follow them up by the respiratory team in outpatient department in 2 to 4 weeks. If the patient is symptomatic and has high-risk characteristics and it is safe to intervene, so the only option is to do the chest drain insertion. And obviously, when you insert chest drain, the patient needs to be admitted, to be reviewed, and the chest drain will be removed when we achieve fully expanded lung. And after discharge, the patient will be reviewed in outpatient department in 2 to 4 weeks. If the patient is symptomatic and has no high risk characteristics, okay, and it is unsafe to intervene, so we will go to the conservative pathway. If the patient is symptomatic and has no high-risk characteristics and it is safe to intervene, here we have 3 options. Those 3 options according to the patient preferences. If some of the patients, they don't want to do the operation or the procedure, so they want to avoid the procedure, we'll go to the conservative pathway. Some of the patients, they want to have rapid symptom relief, but they don't want to stay in the hospital. So this will lead to a pathway of the ambulatory device. This device will be inserted to the patient, and then we will do regular review as an outpatient within 2 to 3 days. And then after that, the device will be removed and the patient will be followed up in outpatient department in 2 to 4 weeks. Or if the patient wants to have rapid symptom relief as a short-term drainage, we'll do needle aspiration. If the needle aspiration resolves the pneumothorax and we achieve the fully expanded lung, so the patient will be discharged and to be reviewed in outpatient department by the respiratory team within 2 to 4 weeks. But if the needle aspiration doesn't resolve the pneumothorax, we'll go to the pathway of chest drain insertion. And looking at the review of the patient, it is common, and you can see that all of the options, they require that the patient to be reviewed within 2 to 4 weeks.
So management of pneumothorax depends on whether the patient is symptomatic or asymptomatic, whether the pneumothorax is primary or secondary, and also depends on the size of the pneumothorax on the posterior-anterior chest X-ray.
Regarding recurrence of pneumothorax, systematic review and meta-analysis in 29 studies collected more than 13,000 patients, they found that overall 1-year recurrence is about 32%. And the greatest risk of recurrence will be in the first year. Female recurrence, the ratio was 3.03. And cessation of smoking found to have 4-fold reduction or 0.28.
So there are 3 points to keep in mind. Number 1, a pneumothorax will resolve up to 4 times faster if a high flow oxygen is administered. Number 2, Internox diffuses into the air spaces and can convert the uncomplicated pneumothorax into a tension pneumothorax. So it shouldn't be used as an analgesia in this setting. And thirdly, the most important thing is that never discharge a patient from emergency department with a diagnosis of a secondary pneumothorax, as a minimum of a supplemental oxygen and a 24 hours observation period is recommended.
Regarding the surgical referral to treat pneumothorax, it is indicated in second ipsilateral pneumothorax, first contralateral pneumothorax, bilateral spontaneous pneumothorax, persistent air leak or failure of lung re-expansion 5 days after the chest drain insertion, first pneumothorax with a significant subpleural blips or bullous disease, and spontaneous hemothorax. The professions at risk are the pilots and divers. There should be an intervention after the first episode, because with the flying, for example, according to Boyle's law, if there is any reduction in pressure, this will lead increase to the volume. So reduction in pressure will lead to increase in the volume and the size of pneumothorax and will make it more serious. They should avoid fly 1 week after the primary pneumothorax. No diving unless the video-assisted thoracoscopy surgical pleurectomy is done. The video-assisted thoracoscopy surgical pleurectomy, the technique is becoming increasingly popular. That is associated with a shorter hospital stay and less post-operative pain. The recurrence rate of more than 5% means that it cannot be recommended in patients wishing to dive. The chemical pleurodesis is an option for patients that refuse the surgery or are considered to be poor candidates for the repair, for the surgical repair. Tetracycline or TAC can be used and administered via the chest drain. However, the failure rate is approximately 10%. Talking about suction for pneumothorax for those patients who had their chest drain inserted. Suction is an application of a negative pressure, and the theory behind it is that there will be a removal of air quicker than the visceral pleural breach, facilitating resolution. The routine use is not recommended by guidelines because there is a risk of re-expansion edema or exacerbation of the visceral hole. The new British Thoracic Society Guidelines for the treatment of pneumothorax in 2023, they are published now in the Royal College of Emergency Medicine Learning website. They are published on the 29th of January 2024. So everyone can have a look on those guidelines through the college website. In summary, smoking is associated with a pneumothorax, recurrence. Breathless patients require suction on their consent. Apply O2 for patients with pneumothorax. The new 2023 British Thoracic Society Guidelines are more conservative. Simple needle aspiration should be considered as the first line. If secondary pneumothorax, use needle aspiration if the size is 1 to 2 centimeter and symptomatic. Small drains are effective as the large drains. Patient should only fly after a week of their pneumothorax, no diving until bilateral surgical pleurectomy is performed. Thank you so much for your listening and all the best.